I don't know, where is Sadanand Shetty? Sadanand? Anyway, I think we will not waste much of time, and we'll proceed with the session on the CTO PCI beyond techniques. You saw excellent techniques in the last two cases, and now we'll go beyond. What is beyond? MDCT evaluation, does it help, and how in Indian scenario? Dr. Rajesh?
Yeah, respected chairpersons, it's a great honor to be here, and let me at the outset express my heartfelt gratitude, Dr. Ganesh, Vijay and the team at IJCTO for making this possible. I'm moving away from techniques we saw. I'm just going to tell you how the multi-slice CT is going to help you in planning and achieving greater success in CTO recanalization than what is possible by using the conventional invasive angiogram. I'll start with the case example. This is a young man, 49-year-old man. He had a history of anterior wall MI some 9 months ago, and he had worsening dyspnea, and he had mild LV dysfunction echo, and MRI had shown a viable myocardial LAD, and he was angiogram was done for finding out what the lesions were and also to achieve a recanalization. This is a picture. You can see the LAD is flush occluded from the left main, hardly seeing any antegrade filling at all. Total occlusion, no track seen antegradely. And see the RCA also, there's no collateralization from the RCA to the left. So here is a situation where you have a complete occlusion of the LAD. We have no idea as to whether there's calcification beyond the lesion, the length of the occlusion, as well as the presence of collaterals, etc., from the invasive angiogram. So we need some other imaging modalities to help us in planning a procedure, also achieving greater success in our procedure. And that's why the role of multi-slice CT helps you in achieving all this. This is a raw image from the multi-slice CT. If you have the pointer, please, the pointer. And you see this, again the CT shows a complete occlusion of the LAD, and you can see a small speck of calcification there right in the middle. There, complete occlusion. See a small stump, you can see a small nipple-like projection here, but the entire vessel is not seen antegradely. With the margins seen, we can have an idea as to approximation of the vessel lumen, at least from this picture. Oh, this has come inverted. We have a 3-dimensional lab in our hospital. So after we got the raw images from the CT, we went about doing a 3D reconstruction of this. Here we can see this is the ramus. The LAD is flush occlusion with a total small stump seen. And then we went about recreating the LAD using 3-dimensional techniques. And this was based on the outer caliber of the vessel, which was outlined on the CT, but there was no contrast filling at all. We can recreate the LAD, we can see the diagonal coming out, we can have an idea as to the caliber of the vessel, and then take pictures and then recreate this model with 3D printing, which has come in great use nowadays. You can see this picture. This is the white thing shows the LAD, which is actually completely occluded, but we have recreated it by using the outer margin of the vessel. And the same thing which is seen as in a conventional caudal projection. We can see the LAD here, and we can have an idea as to the trajectory of the vessel as well as to the caliber of the vessel when you want to plan intervention. This is on the example of a long CTO. This is a conventional angiogram. You can see that there's a totally occluded vessel with some bridging collaterals, but we have no idea as to what is the presence of calcification here or the morphology of the plaque in particular. But this CT on the right side, you can see there's the dense calcification here, not much of calcium in the lumen, and so we can actually calculate the length of the occlusion from the CT images also. So here I come to the limitations of invasive angiogram. It's a luminogram. It just provides incomplete visualization of the occluded vessel and the vessel trajectory. And once you have no idea as to the vessel trajectory or the lumen caliber, we just play around the wires, hit or miss wire crossing. If you're lucky, the wire crosses. If you're unlucky, the wire doesn't cross. So this is, and in the process of using the hit or miss technique, you are actually increasing the risk of complications. Now, what are the advantages of CT over conventional invasive angiogram? It provides better visualization of the occluded coronary segment. It quantitatively evaluates and morphologically and anatomical features of occlusion. It gives us an idea of the distal vessel tortuosity, if there's any bend within the occluded segment, and with 3D reconstruction as is shown here, accurately measure the occlusion length and outline the vessel trajectory. Also, in ostial occlusions, all of us know invasive angiogram is not a good way of going about. This is again on the picture showing the length of the occluded segment, long segment occlusion LAD. You can see the LAD filling distally, but here with the CT images, we can get an idea as to the length of the occlusion. Similarly, what about plaque composition? Is it very important in CTO reconstruction? Yes. If you have an idea as to the presence of calcification, as to the length of the occlusion, whether there's an occlusion beyond the proximal occlusion, this is actually help you in planning your procedure, whether you need to go straight away with your conventional wires or you need to go with the stiffer wires when you have a lot of calcification. Also, when you look at this patient, as all of us know, the single most important determinant of a success of CTO depends upon the extent of calcification within the occluded segment. And this CT is a very, very sensitive way of picking up calcification. The conventional angiogram is very poor as far as picking up coronary calcification is concerned. So here, not only it gives us the idea of the vessel length, it tells us explicitly the presence of calcification. Also, it tells us that the length of the occlusion and also helps us plan the procedure better. And the important thing I want to mention is, if you have a lot of vessel tortuosities, a lot of bends, as we have seen in the previous live case, this CT actually helps us in planning a procedure well. And here you can see this patient has a shepherd's hook origin of the right coronary artery. You can also plan your guiding strategies, your vessels, based on the morphology of CT. But if you look at a conventional angiogram, it will be just a chronic total occlusion with hardly any antegrade filling. Now, having a double CTO, a CTO here, a CTO distally, helps you also in telling you that the possibility of success in this particular patient is going to be on the lower side when you have two chronic total occlusions, which can be picked up on CT very easily. Now, what are the predictors of CT or failure on the CT angiogram? One is the length of the occlusion. The longer the occlusion, as long as 32 millimeter, the chance of success is going to come down. If you have proximal bending, if you have a lot of calcification, and if you have vessel shrinkage, what is called negative remodeling, the chance of success is going to be low. Again, as this diagram shows, that if you have a total occlusion of LAD, you may not see the LAD on the invasive angiogram, but you can see it well, and you actually plan your wire strategies based on this. Now, what is an example of a good, if you want to start CTO in your hospital, if you have a CT like this is a good patient to start your first CTO procedure. Notice this is a very short segment occlusion, hardly any calcification, and this CTO can be recanalized easily with maybe a Fielder XTR wire. Now, this is an example of a difficult CTO on CT angiogram. You can see lots of calcification, long segment occlusion, and multiple occlusions. But then you look at the left-hand side, the conventional angiogram just shows a trickle of contrast antegradely. Now, the important thing is, if you are planning a retrograde canalization, you need to see your collaterals well. Sometimes the invasive angiogram may not show collaterals, but a CT, because of its greater sensitivity, can pick up collaterals with greater clarity than we would see on a conventional angiogram. And this was a study which showed that if the success rate of collateral wire crossing based on CT angiogram was, if the collateral was visible on CT, the success of crossing was considerably high than which is an invisible collateral. And then this other thing which is on CT is called linear. If you see linear thrombus enhancement on CT, this is a good way. This CTO can be recanalized very easily if you have linear thrombus enhancement on CT scan. This is again a study which shows that if you have linear thrombus enhancement, the success of CTO recanalization is on the higher side compared to no linear thrombus enhancement. There's another thing which is called in CT paraphrenology is called a reverse attenuation gradient. Normally, if you have a total occlusion here, if you look at the attenuation distal to the vessel, normally the attenuation should come down because the contrast flow comes down. But here, if you have increased attenuation as you go down a total occlusion, it means there's good collateral flow, and this means that the greater chances of success if you want to attempt retrograde CT canalization. So what is the rationale for combining CT imaging in chronic total occlusion? It actually gives us more information than invasive angiogram and actually helps us achieving greater success. There's a lot of studies which looked at CT and how it helps in CTO recanalization. The important predictors of CTO failure in CT was having calcium more than 50% of the cross-sectional area, having a lot of bends in the vessel, multiple occlusion sites, a blunt stem, and a CTO duration of more than 1 year was an adverse predictor of CTO success based on CT angiogram alone. All of us know the JCTO score is grossly incomplete because it just tells us about the presence of the blunt entry calcification, the presence of bending, as well as occlusion length. It doesn't tell us anything about the duration of the occlusion, nor does it tell us anything about any previous attempts have been made or not. So based on this, a lot of investigators did what is called a CT rectus score, and they said, based on all these parameters of the multiple occlusions, the presence of blunt stem, calcification, bending more than 45 degrees, a previous attempt or not, and the duration of CTO, they came out with a score which is called a CTO rectus score, and this is compared against the JCTO score, and they found the CTO rectus score had greater sensitivity in predicting the success of glide wire crossing within 30 minutes. Now, can a pre-procedural CT improve CTO PCI success rates? Yes, it can. It can better define bending, calcification, the course of ambiguous CTOs, and hence achieve greater success with CTO recanalization. Now, moving away from what we have done so far, we have actually done what is called co-registering of CT images in the radiology lab. We bring it into the cath lab, superimpose those images of the CT and the cath lab procedures, and then plan a wire tracking as well as the trajectory of the vessel, trajectory of the wire crossing based on superimposed images of CT as well as the conventional angiogram. This is an example how in a patient who had a stingray or blunt dissection done, we could actually use this co-registration achieve successful recanalization. And
Dr. Rajesh, your time is over.
yeah, I just want to, this is my summary slide. So the advantage of CT is not only it provides us a good morphological assessment of the plaque, it also gives us a physiological assessment whether the myocardium is viable or not. It also helps us in planning our strategies and also achieving a greater success. I just want to conclude by saying that if you have, just you ought to spend 10,000 rupees more extra on a CT, and nowadays we are using very good, what you call techniques to reduce radiation. So if you have a CT angiogram, if you give your additional information, I'm sure you can achieve greater success with CTO PCI recanalization. Thank you so much.
Thank you, Dr. Rajesh. I think that was a very, very interesting talk. And in the interest of time, we'll take all the questions together at the end. May I now call upon the next speaker, Dr. Anand Rao, and he's going to talk to us on the role of antiplatelets and duration in CTO-PCI.
Chairpersons, ladies and gentlemen, I thank the organizers for having me here. The topic is antiplatelet choice and duration after CTO-PCI. The topic is relatively straightforward, but the data is quite limited. Now, just a preamble to my talk. A CTO is defined as an obstruction of the native coronary artery with TIMI2 flow, and the estimated duration is more than 3 months. A successful PCI is defined as stenosis less than 20% of the vessel diameter with TIMI2 flow estimated by visual, more than TIMI2 flow estimated by visual estimation. In fact, if you look at many of the clinical trials, which are related to DAP treatment, many CTO was conveniently or excluded from these trials. Even the subgroup analysis did not perform or did not analyze whether dual antiplatelet is required or not required for reducing the MACE events at the end of 12 months. So as of now, DAP duration is unknown in cases of CTOs. But if you look at the characteristics of the CTO, they're very complex. There's a lot of atherosclerotic burden over there, calcification, longer lesions, which contributes to high syntax score, and then you end up doing longer stents and multiple stents. This itself puts the patient into a high ischemic risk after the procedure once it's done. I try to search a lot of literature on the guidelines and recommendation of DAP treatment after successful CTO PCI. Not much of data is available. However, all these articles I took out was between 2015 and 2017. This was one of the recent article published in a 2017 article published where they Kugler studied scaffolds compared to everolimus eluting stents for treating CTO, their clinical angiographic follow-up at the end of 9 months and 12 months. They showed that similar recategorization of BVS and everolimus eluting stent for the treatment of CTO, clinically 9 months and even the DAP treatment for 12 months. So they found out that 12 months was the right treatment for DAP in the CTO PCI. This was an article published in CCVD in 2016 where Markovich compared zotarimus eluting stents versus everolimus eluting stents, and they had a follow-up for 12 months. They also came out with the same conclusion that 12 months of DAP treatment is more or less enough. The DAP treatment which was included in all this trial was, let me tell you, it was aspirin and clopidogrel. That was a standard treatment, and that's the standard treatment what we also prescribe right now. This was one article which is interesting, which came out in JACC 2016, where IJCTO analyzed 6 randomized trials, and he found out the duration of the occurrence of MACE at the end of 1 year. And he concluded that procedural complexity is one of the most important factor, and everything has to be individualized. But unlike the other trials, he showed that the long-term DAP treatment, that is at least minimum 1 year, had better MACE events compared to 6 months or 3 months DAP treatment. This was, I feel, is one of the most landmark article, which fortunately was available before this meeting, so I could take out some details from this. This is one of the longest study available to us, where Lee analyzed patients of 512 patients for more than 10 years of DAP duration of less than 12 months and more than 12 months. His conclusion was that it does not make a difference. The MACE events were more or less the same. Let's go to some of the details in this study. What they wanted was the primary outcome was the MACI during follow-up. The secondary outcomes were included MACI, cardiac death, moderate to severe bleeding, which is the concern when you give long-term antiplatelet therapy. So if you look at the MACI, stent thrombosis and all-cause death, the p-value did not differ between 6 months and 12 months. And the most important thing is the bleeding concern. The bleeding consortium score, the GUSTO or TIMI major or minor score showed that number-wise there was some increase in bleeding when you give DAP for more than 12 months. However, the p-values were not significant. In fact, they analyzed it artery-wise also when they looked at the CTO of LAD versus CTO of circumflex and CTO of the right coronary artery. Look at this curve, more or less, they are all in the center. So some favored 12 months, some favored 6 months. So it was concluded by this study of 6 months or 12 months, the outcomes more or less are the same. This was another important study which got published in JACC in 2016, studied by Marty Leon, Greg Stone, Anthony Colombo, and Alexandra Bizet. What they did was they saw the efficacy and safety of dual antiplatelet therapy after complex PCI. Complex PCI was defined as 2 stents, 3 stents, bifurcation, and of course CTO. And they showed that If you look at this graph very carefully, they analyzed it for 12 months, and the upper part of this curve showed a DAP treatment of 3 to 6 months, and the lower part showed the DAP treatment for 12 months. As you go to the right side, it increases the PCI complexity. What they showed was, if your complexity of the procedure is very low, 6 months or 12 months, DAP treatment did not differ. But as you go into more complex lesion, triple stenting, bifurcation stenting, and CTO, your 12 months DAP treatment is much better and reduces the MACE events quite significantly. They came out with a very important statement saying that procedural complexity is an important parameter for tailoring upfront duration of DAP. If you look at the Euro CTO recommendations also, they said that DAP treatment for 12 months was good enough in sirolimus eluting stent with non-erodible matrix, and 6 months in patients with biodegradable polymers. So more or less, it's a standard thing what they have recommended. What about the newer drug? I searched quite a lot about ticagrelor and prasugrel. Unfortunately, in CTO, no studies have been are performed, but there was one ongoing trial which I could pick it up. It's called as P2-BITO registry, where a P2 vital inhibitor utilization in bifurcation and CTO with multiple drug-eluting stents. The principles or hypothesis of this study is to see the thrombosis rate using these 3 molecules, see the thrombosis rate, and which has got high risk setting PCI with BVS and DES. The enrollment is pretty much completed. I think by this year end or early next year, we should be able to get this data. There's another trial which is going on called as Tiger BVS, where Tiger and Absorb, where ticagrelor and Absorb stents were used, and they wanted to see the recovery of vascular function after successful CTO recanalization. The study's dates were, this is a Spanish study, which is October 2014 it started, and now it will be available to us by November 2019. The hypothesis was ticagrelor will show superiority over clopidogrel immediately after CTO PCI. We have to wait and watch for this. What about glycoprotein inhibitors? We don't use at all. I can boldly say that GB2B3 are almost contraindicated, and of course they're controversial. Nobody uses that anymore. In case of perforation, these molecules may enhance complications, then you are in trouble. So by and large, GP2B3 is not recommended. But however, in some case, when you successfully cross the CTO lesion and you end up putting multiple stent, you may have to, you may be compelled to use GP2B3 inhibitors depending on the situation. Or sometimes you have intraprocedural thrombus. There is the one indication where these molecules have to be administered. However, there is no robust clinical data or guidelines available to us. So what is my take on this particular subject? CTO is a complex procedure with multiple hardware involvement. Use of DAP should be considered for longer duration like in any other subset. At least minimum, I think, aspirin, clopidogrel. Our choice of drug would be aspirin, clopidogrel. We have not done using ticagrelor. Of course, we got limited experience, but we have never used ticagrelor and prasugrel as it. So our choice of drug remains aspirin, clopidogrel combination, at least minimum to the tune of 1 year. However, we don't have any data, but we have a strong feeling that the rates of MACI and MACE will come down significantly once ticagrelor and prasugrel will be used. The ongoing 2 studies will definitely show us. We have to wait and watch, maybe next year. But my last take point would be, you have to tailor-made this particular treatment. The risk benefit should be calculated for stopping or continuing DAPT, and it should be individualized to assess and to trade off between future risk of ischemia and bleeding. Thank you.
Thank you, Anand. We will discuss at the end, I think, because of short of time. Okay. And I would request Dr. Jamshed Dalal to speak on the role of NOAC in AF who undergoes CTO PCI. Dr. Dalal.
The complex of using NOACs and antiplatelet agents is fairly new. So really we don't have any data specifically related to the combination of single or dual antiplatelets and NOACs in the situation of CTO. So most of the studies have been done in angioplasty, which are not necessary complex. The important aspect to remember when you have a patient with stroke and ACS both is that you have to prevent stent thrombosis and you have to prevent stroke. And therefore, you have to use the combination of antiplatelets and the combination of oral anticoagulation. And that produces, of course, major bleeding. So the issue here is more of bleeding rather than of long-term clinical benefits. And that, of course, is the art of medicine. Can I have a pointer also? If you look at this is an experimental study, but it shows it quite well. If you look at the placebo, the first slide, in a stent without any drugs, you can see that the stent completely thromboses off. If you add dual antiplatelets, you can see that the thrombus is much less. And when you add NOAC, then clearly you see that the stent thrombus load is much less. So clearly, experimentally, there is definite benefit in terms of combining the two. The first trial which really combined the two was the WAS trial. Most of you know that. It was a combination of warfarin, not NOACs, warfarin, and looking at whether aspirin, clopidogrel in combination with warfarin or using one alone was better. And this was the first time we found that a single drug, clopidogrel with warfarin, was actually better in terms of bleeding reduction without increase of any ischemic events. So clearly, this was the first one which pointed towards the fact that using a dual antiplatelet was not essential when you had an anticoagulation on board. The ATLAS study was the first to look at the combination of NOACs, in this case rivaroxaban, and looking at association with aspirin and with addition of dual antiplatelets. But they used very small doses. This is important to remember, 2.5 BD and 5 BD compared to the usual 20 milligrams daily that we use. The addition of a small dose of rivaroxaban definitely had a benefit. It had a reduction of the endpoints of cardiovascular death MI, cardiovascular death alone, and in fact all-cause mortality. So clearly the addition of rivaroxaban reduced the cardiovascular endpoints. It also reduced significantly the stent thrombosis. So clearly there was a benefit in terms of combining these drugs. But of course you had to pay a price for it. And that was much so when you had 5 milligrams BD. 5 milligrams BD is still a small dose compared to what is used for SPAF. And you can see that with 2.5 BD, and if you look at the important complications, the fatal bleeding and the fatal intracranial hemorrhage, there's no difference. Of course, my question still remains that if you have a patient who's got atrial fibrillation, which is the reason why you want to use a NOAC in the first place, then 2.5 milligrams BD probably won't prevent the stroke. So maybe you're looking at the benefit in terms of ACS, but clearly in terms of stroke prevention, this dose would certainly not be adequate. So the number of trials which are in progress, we don't have the result. There's one with dabigatran along with P2Y inhibitors and the redual PCI, which is still in progress. There's a trial called the Augustus trial with apixaban, and same again, warfarin versus apixaban, aspirin, placebo. We still don't have the results of that. But we do have the results of the Pioneer trial. The Pioneer trial is patients with non-valvulative flip undergoing PCI with stent placement, and a fairly large number of patients, 2,000. And again, they divided into three groups. Rivaroxaban, 15 milligrams plus single antiplatelet. Rivaroxaban 2.5 versus dual antiplatelets like in the ATLAS trial, and warfarin versus dual antiplatelets. And then after a 6-month period, the drug, this was continued. This was changed to 15 milligrams OD plus low-dose aspirin, and this was oral anticoagulation with warfarin plus aspirin. So interestingly, a different group of combinations, and I think for first time they've used a dose of rivaroxaban 15 milligrams, which I think is an optimal or a reasonable dose for stroke prevention as well. So this is the first time I think that we are looking at stroke prevention in addition. Interesting, if you look at the efficacy in terms of the endpoint, if you look at group 1, which is the warfarin group, or you look at the 2.5 milligrams rivaroxaban with dual antiplatelets, or you look at 15 milligrams with a single antiplatelet, clearly the effects were the same. So you could use any of the three and you could get equal efficacy. But the important difference here is that the bleeding much more in the warfarin group. And of course, that's anticipated. You got warfarin plus dual antiplatelets, whereas if you use a small dose of rivaroxaban plus dual antiplatelets, the bleeding is less. But more interestingly, if you use 15 milligrams of rivaroxaban plus a single antiplatelet, then the effect is good because you're going to get stroke prevention, you're going to get less cardiovascular ischemic effects, and you're not going to get bleeding. So I think, in my mind at least, this seems a reasonable combination when you want to prevent a stroke in a patient who's on NOVAX and who's going for ACS and who's going to be on antiplatelet therapy. So I think the PIONEER study has given great benefit. Now, we all know that we always say that once you use warfarin or you use NOVAX, then there's a contraindication to ticagrelor or prasugrel. So far, we would never use it. We would use either clopidogrel or aspirin clopidogrel. Now, the Gemini ACS study actually looked at rivaroxaban versus aspirin and looked at both clopidogrel and ticagrelor. So let's see what they found. Now, the objective of the study was to look at bleeding problems. They were not really looking at ischemic events. They were looking at the safety of the combination of aspirin with clopidogrel and ticagrelor with rivaroxaban. And the population was mainly patients with ACS. They had either acute, most of them had acute invasive treatment. And if you can see again, large number of patients, 1,000 plus, and again divided into a group of rivaroxaban 2.5 milligrams plus clopidogrel or aspirin plus clopidogrel. So here it was clopidogrel, rivaroxaban, clopidogrel plus aspirin. And the second group had rivaroxaban 2.5 milligrams with ticagrelor. So now you got clopidogrel 2.5 with clopidogrel, and you got rivaroxaban 2.5 with ticagrelor. So now you got a good head-to-head comparison of clopidogrel versus ticagrelor with a small dose of rivaroxaban. And the last was aspirin plus ticagrelor, which of course there are trials for comparison of this. So I think the main aim that we need to look for is this combination with ticagrelor and compare it with clopidogrel. And the primary endpoint, as I mentioned, was significant bleeding, because that's what they really wanted to know. And of course, the efficacy in terms of exploratory second points was endpoints of usual endpoints of MI, death, stent thrombosis, and all-cause mortality. Just to point out here that PCI was performed in a large number of patients, and you can see the various groups more or less equally divided. So let's look at the primary thing that they looked at, and that was the bleeding. And if you look at the bleeding, and if you look at the first one here, this non-CABG bleeding, non-CABG major or minor, non-CABG major, minor, requiring medical attention, and you can see that rivaroxaban in the small dose of 2.5 milligram showed equal bleeding rates when given with a combination of clopidogrel or ticagrelor. So clearly, using ticagrelor with a small dose of rivaroxaban wasn't more harmful than using clopidogrel. So that's definitely a new educational point. So therefore, let's look at the efficacy point of view. This was not the primary aim, but they did look at efficacy. And if you look at the total CV death, MI, etc., if you look at CV death or MI separately, stroke, stent thrombosis, all-cause death, and all-cause stent thrombosis, again, the rates of endpoint efficacy were similar in all the treatment groups. However, this was not big enough to look at ischemic endpoints, but certainly 1,000 plus patients, and clearly there are no more ischemic events in this combination groups. And of course, the point that I really wanted to make was the clopidogrel group and looking at all the endpoints versus the ticagrelor group and looking at the endpoints, and the bleeding outwards are similar between rivaroxaban and ticagrelor. So at least now we have some more evidence to suggest that ticagrelor does not produce more bleeding in addition to rivaroxaban. But please do note, the dose of rivaroxaban was 2.5 milligrams twice a day, not the 15 or 20 milligrams that we would use in a stroke. I think that's important to remember. Of course, we now have anti-bleeding prevention of antidotes available. I was speaking just day before yesterday. The antidote to dabigatran should be available to us next month, and it costs 1,500 euros in abroad, so it's probably going to cost us a pretty hefty amount. It won't be available in every hospital unless the hospital buys it, but they probably keep it in a number of centers. And well, in case you have a patient ACS and has major bleeding because he's on NOVAX, this would have a very quick effect in terms of reversal of these agents. I think these are guidelines which you all are well aware of. When you have to combine these drugs, what would you do? If a patient has got a high bleeding risk and has a stent, then of course you give triple therapy. That means aspirin, clopidogrel, and either NOAC or a warfarin for only 4 to 6 weeks. If it's a low bleeding risk, you can continue for 6 months. After that, you clearly shift to one, either aspirin or clopidogrel with warfarin or rivaroxaban. The voice trial suggests that you use clopidogrel, and very importantly, after 1 year, even after a stent, you don't need to put any antiplatelet agent at all. You can just continue with a NOAC or a warfarin. And initially, when they came out with the guidelines, they said you could not use ticagrelor or prasugrel. Gemini trial suggests that probably ticagrelor may be used, but again, very important to remember the dose reduction in the Gemini trial compared to the others. Just want to add with this slide the very recent topic study which suggested that at the end of 1 month, if the patient has no events, you could shift them from ticagrelor or prasugrel onto clopidogrel. You reduce the bleeding, but you don't reduce the endpoints. So the ischemic endpoints remain the same, but bleeding was significantly reduced when you change them. So this may make it easy. You may use ticagrelor with a patient who's on Novax for stroke prevention, and then maybe use this trial to say that after 1 month, if the patient has no problem, shift him to clopidogrel. Maybe it would be safer. I think we don't have the answers to all the problems. The trials have been using small doses of rivaroxaban. We really don't know what to do for patients on 20 milligrams of rivaroxaban or full dose of apixaban, and he's going to be on dual antiplatelets, and if he's of course going to bleed or not. So I think a lot of answers needs to be due, but this is what we have at the moment. Thank you very much.
Well, we come to the next presentation by Dr. Ganesh Kumar, long-term outcomes of full metal jacket. Ganesh.
Thank you, Chairpersons. I thought this topic was quite relevant for today's meeting because we have been, whether CTO or not CTO, we've been using a lot of stents and doing a full metal jacket. By definition, the full metal jacket is when stent lengths are more than 60 millimeters. So the complexities of PCI of late over a period of last 1 decade has obviously seen a tremendous growth in full metal jackets, and initially in the beginning of the decade or even after even 5 years back, we were very skeptical about using full metal jackets, and we would criticize our colleagues saying that, oh, this patient will come back with restenosis or MACE rates. So let's see what our talk is going to be on. This is a case which I'll start with a couple of cases and then I take you to the data. A case which I did in 2010, a 57-year-old diabetic with unstable angina and triple vessel disease was planned for a multivessel PCI. And this was in fact started by my colleague Dr. Rahul, who is now there in Navi Mumbai. A straightforward looking lesion in the right coronary artery. Somehow it got dissected. Once it got dissected with the critical lesions in circumflex and LAD, the patient crashed. And I was showing in the lunch-on session that at times we need to use star techniques, and this was one case where I used a star technique of entering into a false lumen and exiting to a true lumen because there was no time. And by doing that, I created a long, the entire mid-RCA was through the false passage. On the right side picture, you can see the whole thing is a false passage, and in the distal RCA, I came to the true lumen. And I had to put multiple stents, starting from distal RCA, mid-RCA, and proximal RCA. I lost the PD that particular day, I thought, and this is how the end result looked on the right side. 3 years from then, I did a follow-up angio on him. Of course, the left side stents are patent, and this is how it looked like. It looked beautiful, and even the PDA had come back. So this is one of the follow-ups of full metal jacket, which I wanted to share with you. Another 60-year-old lady, unstable angina, triple vessel disease, planned for multivessel PCI with the right artery having a CTO. And when you open up these CTOs, you see the whole thing is diffusely diseased. I mean, where do you place the stent, lower down? Whether you do only a focal stenting in the mid-RCA or you go right up to the down and make a full metal jacket. I, for one, believe in putting stent from healthy to healthy segment and ended up putting long stents and make a full metal jacket. After 5 years, in the month of March, we did an angiogram on him, on her, and we found that it's beautifully patent. So these are the cases which gives us a lot of confidence. A case which you have done full metal jacket almost half a decade back, and you see that it is beautifully patent. 69-year-old male, 2004 underwent an angioplasty at JJ Hospital. I don't have the detail, perhaps it was a bare metal stent, and now the last week I had to open this artery because one of the feeder arteries to this is having a lesion, a small OM which is supplying this right coronary artery, a CTO in the stent. So I open up this, it was done on 3rd of this month, open up this, and this is how it looks. I do an IVUS and I see right up to the PD, PLV, the whole thing is at least 50% diffuse disease, and there is no landing area for me to put a stent. So these are the type of lesions where I end up putting full metal jacket. And just another case which is not similar to this. For the sake of discussion, I'll tell you, this I had done around 5 years back, 7 years back in 2010. On the left side, you see disease in the proximal mid RCA and there is ulcerated lesion in the distal RCA. I put stents in the proximal mid and the distal RCA, and this is the area I had left it. That time I didn't do an IVUS, but perhaps if I had done IVUS, this would have been a 50% entire diffuse disease. Today, I would do it differently. I would put a full metal jacket. What did I get? Again, this case, I did it on 6th of, 3 days back. Patient developed a total occlusion, it's a chronic occlusion. The stents on the top, proximal and mid RCA is patent. The stent below, which is not visualized on the left side, was patent. And I ended up opening the CTO and put a stent covering the distal stent. My landing zone was in the distal stent and in the proximal stent. There is an insignificant ISR in the mid RCA stent, which I left it alone because FFR was 0.86. This brings us to a debate whether we should put a full metal jacket or whether we should do spot stentings like this. I mean, I did a little bit of search on the data that we have got. There are concerns, obviously, of full metal jackets, but what is the data saying? This is one of the paper which was published this month in the Journal of Cardiology, where 68 patients received a complete metal jacket and 53 patients received incomplete metal jacket. 30% of these patients had chronic total occlusion in both the arms. And the MACE rates were, in fact, surprisingly lower in the complete metal jacket compared to an incomplete metal jacket, full metal jacket. Both the midterm MACE was significantly less, and it showed favorable for full metal jacket in patients having diffuse, especially long coronary artery lesions. Another paper, which was published in 2016 in Journal of Cardiology, 120 patients followed up for a period of 41 months plus minus 21 months. 29% again had CTOs. 14 patients had at least one major cardiac event, while 7 patients underwent clinically driven TLR. So this was another favorable study which showed that the full metal jacket had lesser events compared to the patients who were followed up in their center. These 120 patients who were followed up had a very low MACE rates. Another paper, 2009 paper, these are the stents which were, full metal jackets were made in Antonio Colombo Center. In almost 658 full metal jackets were made in 617 patients. Again, more than 30% patients were CTOs. The median duration of follow-up was 38 months. The all-cause mortality, the cardiac death, and non-procedural related MI were all low. The target lesion revascularization rate were around 23%. So what they went on to conclude in this particular paper is, in 2009, they were all the first generation drug-eluting stents, and this is what the data they got. So they believe that by putting the newer stents, the rates would further be lower than what they got. Another paper from published in CCI, 300 patients, median duration of 75 months. Again, the first generation drug-eluting stents. Same conclusion, the MACE rates were quite low, and the newer generation stents would lead to a further reduction in the TLR and TVR. One more paper which came in 2013. PCI using a full metal jacket was efficacious but associated with higher risk of stent thrombosis. However, there was no difference in MACE rates that were observed between CTO arm and the non-CTO arm. So this was like a more of a neutral paper. This is the last paper which I think I searched. 77 symptomatic patients treated with overlapping everolimus eluting stents. Almost 40% of the patients were having CTO. There were no difference in the adverse outcomes in the MACE between the CTO and the non-CTO group. Why CTO and non-CTO becomes important? Because in CTO we do create a lot of false passages and your stents lie from the true lumen to a false lumen to a true lumen. So you might argue saying that in CTO subsets you might have higher rate of restenosis or MACE rates or in the form of thrombosis, but that's not true anymore. So to address the concerns, DES have got very lower rates of restenosis compared to BMS. Yes, strut thickness of lesser than 80 microns, which we are having now, will further lead to an improvement in full metal jackets. BVS data we don't have as yet as far as full metal jackets are concerned, and this should might be a game changer, the BVS, we don't know. Full metal jackets is no more a consequence of complication, but rather has become a routine strategy in most of the operators nowadays. There is no difference between a CTO and a non-CTO full metal jackets. And the most important thing is when you are using imaging and doing a right sizing of the stents, perhaps that will be the way forward. Thank you very much.
Thank you, Ganesh. And with that, we'll call on Dr. Kane for the last topic of the session on how to minimize radiation during long CTO PCI.
How do I do this? We'll ask questions.
We will, Banu will discuss at the end, yeah. We will just finish this one.
Respected chairpersons, at the outset, let me thank Dr. Ganesh for giving me this opportunity. I'm not an expert on radiation, obviously not, but I prepared this talk for the sake of all of us in consultation with the radiation physicists from Atomic Energy and the CAT lab companies, engineers that we have, Siemens and Philips. And I presume that this information will help you, and it has helped me and your patients live longer, maybe. We all know this. This is well known that ionizing radiation can be harmful. There's nothing new about it. All of us discuss about it, but never really pay much attention to it and just forget about it. Maybe because we don't see it, that's why we are not bothered about it. But we also know, and we at the back of our mind, that it can cause cancers or something later in life in some individuals. But acutely at that time when you're doing the procedure or in the cath lab, that is very much at the back of everybody's, means that is never in your mind that what can happen and radiation can cause you. I was just thinking why that should be, like we should be concerned, but we are not. But why should that happen? Probably we are so engrossed in the thrill and challenges of doing a complex case that we have no time to think about what the radiation is causing. Our training has never probably stressed on protection beyond a lead apron and sometimes maybe a thyroid shield. Maybe that only those people who want to impress others with those sexy lead eyeglasses, they wear only those lead glasses, other people don't want to wear it. And maybe we have seen our seniors, we have seen people working without it and probably nothing has happened to them, so nothing will happen to us. It's also possible, and I'm sure about it, that the hospital administration is not bothered, because I have found out at many places some of the lead shields are missing, the upper one or lower one. And you ask the technician, they said it did not come with the machine. Then you talk to the administration, they said no, we'll purchase it. 4 or 5 years have gone by, that thing has never come. And it is also quite possible that our Atomic Energy Board, which is supposed to modulate all this or moderate all this, they are also not strict about healthcare professionals, because I know of some places where lead badges are brought down only during the inspection. They get it from somebody, they show that this is these people, these doctors, and then they return it after those ARB people go, that the lead these things are there, the dosimeters are there. So there are lots of lacunae and everybody has to take interest, and this is in interest of self-interest as well as our patient interest. Let's see what radiation causes. Basically, they're supposed to cause 2 types of effects, what are called as stochastic and deterministic. Stochastic simply means that you cannot statistically actually know, because there's a no dose response, escalation response to the effect. It can come with a very low dose or it may come at any dose, so there is no statistical prediction, and that's how the cancers or hereditary disorders can come. And some people will get affected even at a low dose, some people may get affected at a very high dose, but there is no statistical prediction. Whereas deterministic effects are definitely dose related, so you know if this much dose is crossed acutely, then you're likely to get lens injury or the skin injury or the in the patient or the performing doctor or the staff. Staff doses obviously can be reduced by reducing the patient dose, because that's the main thing, the dose is to the patient, and obviously good radiation protection policies. Just to show you that the number of vessels you treat also increases radiation, and CTO, of course, there's high radiation as shown here. And what are the radiation factors which affect? There are patient factors and there are operator or the lab factors, hospital factors. Obviously the patient factors, that body habitus, disease complexity, we cannot modify that, so you have no control over that. But obviously the operator factors are the ones which we need to take care of, and a little bit of a care if we take will help go a long way in protecting ourselves as well as the patients. And these are a number of factors, all of us know that. I'm not going to go into details, but I'm going to show some of them as the thing processes. Patient dose is nowadays measured by something what is called as air karma. Karma means kinetic energy per unit mass, and that's measured just below the level of the patient. Patient lies down, it is measured in the air, just below the patient's body. That's why it's called air karma. So it is actually not the skin dose, but very close to the skin dose that the patient is going to receive. So you can measure it with an equipment, so that's how it is measured. And all our cath labs are nowadays equipped, the modern cath labs. Let me tell you, there are people working in areas which probably don't have a very good cath labs, and they might be getting exposed to a lot of more radiation because the sophisticated cath labs are not present there. So they have to be extremely careful, especially if they're going to do CTOs and long procedures. But most of the major hospitals have labs which give you this information of what is the air karma product, what is the fluoroscopy time, how much is the gray that you are exposing the patient's body to, and this should be taken into. Let me be very frank with you, though I also do CTOs, I have still not bothered to do all this and look at this. You know, we look at it maybe sometimes just when I have to give a talk or something happens, and then we say, let's look at it. But this should be, and now internationally, if I am not mistaken, every case has to be documented and it has to be entered into a logbook and it has to be discussed in your cath meetings. Only that is the way you can improve upon. So what is happening? Where are you making a mistake? Where can you improve? All those things are important. So you can get your fluoro time, you can get your gray, exposure of the patient. So in the cath lab, medical staff is mainly exposed to scattered radiation. And where does the scattered radiation come from? The maximum radiation comes from the patient. Always remember, once the X-rays pass through the patient, the scatter is maximum there. Of course, it can come from the X-ray tube itself, but the maximum radiation comes from the patient's body once it goes into the patient, because the beam is directed in one straight line or in an angle to the patient, but beyond the patient you have no control over it. Depending upon the body habitus, the X-rays may get diffracted in any direction, and so you have to take care and you have to have all these shields. Now, the basic radiation protection rules, the ARB has a thing called it is all over the world, it's called ALARA, means how to reduce as low as possible. Reasonably possible, and that can be done by, if you can stand beyond as far away from the source of the radiation, which is whatever is possible. If you don't have to do something with the patient, especially an anesthetist or a nurse, please don't make them stand near the patient's head, so they are right at the X-ray tube, and even the operator, whoever, can stay away, because as you go away, it comes down by inverse square law. So remarkable fall in radiation that you get. Minimum exposure time, we see sometimes in cath lab, we keep on discussing politics, this, that, and the case is going on and we are standing there with a lead apron. Should not be done, because finally you are getting radiation and you don't know what radiation dose is going to cause what problem in which patient. As I told you, the stochastic effects can come at any dose and anybody, so there is no way to predict that. Though the deterministic effects like skin, lens and all may be predicted. So, and whatever you do, you can see from this, some X-rays are going to come to you. You use lead apron, you put this shield, that shield. It cannot be zero when you are in the environment. So it is best to be away and best to protect yourself and be in the suite as less a time as possible when you have to do your work, not otherwise. The modern machines give you a lot of good things by which you can reduce the patient dose and subsequently your own dose. You have the fluoro time, you have the fluoro speed, 7.5 frames, 15 frames, 30 frames, you have fluoro and cine. So whenever you do a CTO especially, it is now mandatory that you do majority of your procedure under fluoro and fluoro store and rewind the fluoro and see it. Use cine as less as possible, because every time you press the cine, your radiation can be 10 to 60 times more as compared to the fluoro. So you can imagine, you want to take the radiation. Many times we are obsessed with seeing a good quality image. So we say, no, 7.5 is not enough. We want 50, we want 30 because I can't see it properly. Magnify it. Every time you magnify, your radiation is going to go up. So somewhere you have to compromise, unless it is absolutely essential and you are getting stuck somewhere. Try to use the lowest fluoro. Use what is called as a pulse fluoro, which gives you pulses of fluoro, not a continuous fluoro. Don't use cine as much as possible, maybe only at the end to document your final result. And that is how you can probably reduce the dose to the patient and subsequently the dose to you and the other people. There are obviously technological progresses, dose awareness and real-time modification. There are hardware improvements in the cath lab machines itself, but very few people may have access to the technologically high-end labs. You know, we all work in different labs, and one has to know what is the situation. It's not just reading this that, okay, these things are there. They may not be present in some town where you're working, and they may have bought a lab which does not have proper shields, don't have this, don't have that. So it is very important. Some of these modern machines can give you a three-dimensional view of what is the dose at what level of the patient in different areas of the skin. Toshiba has that. Siemens has this where they can give you, the detectors have improved a lot, and now you have what is called as a crystalline silicon detector. That's the latest among the Siemens machine, which at a very low dose can give you a very good quality image. What we have at Hinduja and many other labs, which is also just bought about 1.5 years back, is amorphous silicon detector, which is also good as compared to the previous ones, but the crystalline silicon detector is the latest and the best, which can reduce the dose and give you a good quality image. So it's extremely important to know what you are using. Philips has this hardware by which they can process the images, and at low frame rates also, by processing the image, they can give you a good quality image. So all these things have to be used and known, and you have to find out what are the things that are available. Then only the engineers will tell you, because many times you don't even know. You just do the case, press the fluoro, press the cine, and go home saying that you have done a very good case. It is essential that we must know as the case progresses how much is the grace which the patient is receiving, because patient gets the maximum burden. But he will get the burden only maybe once if you are doing the procedure. You are getting the burden every day or every procedure that you are doing reflected from the patient. So every time the first notification should come by 2 to 3 grays, and by 5 grays the upper limit where you are supposed to stop if you cannot finish the case by then, because beyond that the chance of skin damage and skin ulcerations are very high. So this thing has to be there ingrained into the cath lab personnel, so they inform you. There has to be a logbook to know which case, what is the fluoro time, what is the grace that you have irradiated the patient with, and then only you can calculate. So this is one of the major problems, that because the patient is the major person who gets all this burden, so skin problems are very high. So one of the ways of reducing this is, I'll tell you something which I did, which I realized I've done a wrong thing. The view in LED ostial occlusion was only alveocaudal. You could see in only that view. I worked for almost an hour, and then I realized, what am I doing? Means the patient is irradiated in the same view all the time in one particular view, because the other views don't show you that lesion. So, but then you have to be careful, because then you have to be very careful to see the skin, what's happening, what is the irradiation that you have done. So please take all these things, they are very important to know. And some of this is picked up from some of the Western hospitals where they do a lot of CTOs. So they have this database, they have periodic meetings, quality assurance, there is a radiation protection officer, and every cath meeting this is discussed, what has been the radiation to individual doctors, individual staff. I think we are very far away from that, but even if we know that these things are possible, maybe some of us can implement, we can insist on our authorities to do this. And especially they say if you want to do a staged procedure, if you want to do a different vessel from the previous one, you should wait for at least 4 to 6 weeks. If you want to do the same vessel, then you should also wait at least for 12 weeks. And you should always check the back of the patient. There may be already an ulcer forming there, or it might be the precursor there. So I doubt we really check the back of a patient. We don't have even time to look at the front of the patient. So there's no question of checking the back of the patients. So these are all elderly patients with CTOs. Visible skin changes you have to look for and take care. So ladies and gentlemen, just not to scare you, because I want that all of us should do long CTOs for a long time and live very long, and the patient should also live. So radiation is potentially toxic, and CTO patients are at particular risk. Upfront strategies to minimize exposure to patients and staff can be devised. Ongoing feedback during cases can further improve and help to attenuate the risk to the patient and the doctor and the staff. And technological innovation that will always happen, and that will also help to minimize the patient and staff risk. Thank you very much for your attention.
Ganesh, we have time for some questions. 3 live questions. Any questions? Any comments? Jimmy?
You can give your own experience of 40 years of what you have to say here, I will ask you.
That is working.
Yeah.
That one.
I just wanted, which one? They go here.
Yeah.
Every time he moves from there, you are starting that. So you have to start the one where he is moving now.
No, I just wanted to give one point. Just about a few days ago, one of our colleagues was found to have a very high radiation. And the reason for that was that he had left the badge outside rather than inside. And the end result was that we got a very severe letter from BRC. He was asked to immediately stop doing any cath lab work or enter the cath lab. He's got a long process to undergo now. He has to go to BRC, he's got to fill up various forms, he's undergone a full physical checkup, he has to have a full chromosomal evaluation, and he's been told that it will take him at least 1.5 months before he can restart cath. So remember, it can be a big financial loss to you as well if you find out that you are radiated.
I just want to ask sir, because he's been doing procedure for 40 years. How you are taken care, all along? Because you're all the time working so much in the lab. I've seen you right from a college days, What is how you are taken?
See, I think there are some few basic things that one has to observe. First of all, I must say that the X-ray companies or the cath machine companies made a tremendous advances. I think we had some, in the beginning, very basic X-ray machines in which the radiations were awful. We really did not know how to protect all that we had, some lead apron and the shield which we used to wear on the thyroid. But I think slowly and slowly we have understood that it's very important that the companies have taken all the precautions to see that the radiation dose is markedly reduced. Simple precaution in the beginning we used to take was one, that the exposure to the radiation is the square root of your distance from the table. So longer the distance between you and the table, less is the radiation dose. So I think that's what we used to keep, that as far as possible, we always used to keep ourselves away from the table, number one. Number two, there's always a shield available, which of course nowadays I don't use because the machines have got a tremendous safety issues because the radiation dose, scattered radiation dose is very much minimized. But in those days we used to always invariably put the lead shield between ourselves and the patient. That used to take care of the radiation or the scattered radiation. Third thing is, always we used to wear the badge. Without wearing the badge, one should not enter into the cath lab. Third thing is, I think lately now all the lead glasses have come, and I think all those guys who are doing the CTO interventions where the procedure time is very long, ensure that it's not only the lead glasses, but also I think something like a monkey cap nowadays you get. So I think wear a monkey cap if your exposure time is going to be very long. Third thing is you take a break. And when you work in a place like say Sion Hospital, KM Hospital, where you have to really do long procedures, many procedures, give chance or actually encourage your younger ones to do the procedure. I think all of them were given chance to do the procedure so that our actual radiation dose were markedly reduced and minimized. I think these are some of the precautions that we should take. And of course, as I said, it is kind of a hand in glove with the guys who manufacture these equipments, which have made the equipment very, very, very safe. As a matter of fact, the Philips equipment Clarity has got actually 50% dose reduction, scattered dose reduction as compared to the earlier version. So as a matter of fact, what we bought 2 years earlier, we immediately changed. The complete overhaul was done, and the company came forward and gave us the newer equipment with a 50% reduction. So anytime you find that there's an opportunity to reduce dose, I think do that.
So I think I've just got an intimation that we are ready to go live. So I think maybe the rest of the questions can be taken offline. And this session is closed. I would like to invite the chairpersons for the next session, Dr. Ganesh Kumar and Dr. Okamuru, please.